Good morning, ladies and gentlemen. The topic of today's lecture is quite interesting, and this lecture comprises of diverse conditions with huge psychological overlay, and these conditions are labeled under the heading of mucocutaneous pain syndromes. Mucocutaneous pain syndromes typically involve head and neck and mouth. There is a related condition which is known as the genital dysesthetic syndromes. This condition involves the vulvodynia, vestibulodynia, and pinoscrotodynia. And these conditions will also be discussed. A common thing among all these conditions is that there are no known organic causes identified except in post-herpetic neuralgia and trigeminal trophic syndrome. And the causes is actually a complex physiological interaction between the peripheral and cranial nervous system. To establish this diagnosis, it is essential that all the known organic causes must be excluded, and the management of such patients usually require a multidisciplinary approach. The dysesthetic syndrome comprises of heterogeneous group of disorders which are associated with abnormal sensations in the skin. Any known demonstrable cause of these abnormal sensations cannot be found. There are no clinical signs. However, there will be signs of excoriation, rubbing, or skin traumatization. And these disorders may be divided into those with no known demonstrable neurological cause and those with known demonstrable neurological causes. The burning mouth syndrome. This is one of the very common complaints seen in middle-aged and old individuals with a sensation of continuous burning in the mouth and altered taste sensations, for which no dental or systemic cause can be identified, and there are no gross clinical signs within the oral cavity. This is particularly encountered in perimenopausal women, and it is very difficult to establish the incidence and prevalence of this condition, and is often a diagnosis of exclusion. And the prevalence is not less, and it is about 1%. The peak is around 50 to 60 years, and female-male ratio is approximately 20:1. The associated diseases, the patient often has a history of mental health problems, most commonly anxiety and depression, and exclusion of other organic oral conditions should be excluded. Pathophysiology. The burning mouth syndrome is most likely a form of neuropathic pain. It is known that some individuals have increased number of taste buds, so-called as the super tasters. It is proposed that patients with burning mouth syndrome, the neuropathic changes inside the taste neuronal connections induce this burning sensation. So this burning mouth syndrome is common in those individuals who have genetically more number of taste buds. The burning mouth syndrome is related to damage to chorda tympani during the removal of wisdom teeth, which is a very common extraction. Clinical features. The patient presents with long history of increased oral burning, pain or discomfort. Symptoms may be intermittent or continuous. Most frequent site of symptom is the tongue, but it also involves the lip and occasionally the whole oral mucosa. but the symptoms do not radiate out of the mouth. Patient commonly describe dysgeusia, which is an altered taste sensations, and many describe the taste sensation as metallic or bitter. And it is often associated with dryness of mouth or xerostomia. Burning pain in the mouth is triggered by food with sharp taste sensations like spicy or acidic food. However, in most patients, food and drink relieves the pain, at least temporarily. Symptoms vary in severity throughout the day, being worse towards the end of the day. Some describe relatively mild pain, and most describe severe pain. On examination, oral mucosa looks normal, and there is no objective evidence of xerostomia. Some patients may have fissured or geographic tongue. The differential diagnosis which need to be excluded is that of several organic intraoral diseases like lichen planus, like aphthous ulcers, but this is the diagnosis of exclusion. And if there is any evidence of organic disease, then you must treat that disease. And then this patient will not be labeled as burning mouth syndrome. There is no classification of severity of burning mouth syndrome. Complications and comorbidities. Burning mouth syndrome may be associated with anxiety and depression. Most indicate the disease is severely affecting their quality of life. Prognosis is variable. A spontaneous remission rate in 20% after 7 years and only 3% after 5 years. The treatment ladder. Detailed explanation and reassurance that this is not an organic disease and there is a lot of neurological overlay. Then Selagogues and oral lubricants should be prescribed. Clonazepam 1 milligram sucked slowly is shown to be of help, but the patient end up swallowing the tablet and hence getting exposed to the systemic side effect of the drug. Lidocaine gel is applied topically. Benzodiazepine mouthwash is also prescribed. So all these are non-specific treatments. Second line is cognitive behavioral therapy. And third line are the alpha-lipoic acid, gabapentin, antidepressants like SSRIs, paroxetine, duloxetine, all used with limited benefits. The second disease to be discussed is the post-herpetic neuralgia, which is the neuropathic pain that develops in the distribution of the nerve affected by herpes zoster virus. It is a persistent pain 3 to 6 months after herpes zoster infection. Post-herpetic neuralgia presents with burning, stabbing, or itchy pain with sharp exacerbations and associated sensory changes. If it involves the facial nerve, the pain is felt in the ear and in the tongue. If it involves the trigeminal nerve, the ensuing facial or eye pain can be very severe. Post-herpetic neuralgia, if very severe, results in low mood, poor sleep, and social isolation. Epidemiology. A primary care study showed an incidence of around 3.4 per 1,000 patients per year. The risk of developing post-herpetic neuralgia 1 month after acute herpes zoster is 6.5%. So quite a high percentage. It is more commonly seen in the elderly over 55-year patients. Male-female ratio is equal. Ethnicity has no effect. So generally, it's a disease of old age, especially when the antivirals are not given to patients timely. Predisposing factors. Herpes zoster is most likely to affect the immunocompromised in elderly patients, and it is more serious in those suffering from severe or disseminated rash and those involving the ophthalmic nerve, ophthalmic division of trigeminal nerve, and with past history of anxiety. Pathology. Skin from 70% of post-herpetic neuralgic patients demonstrate loss of function and degeneration of small fiber efferents in the affected dermatome. Ectopic impulses may occur, and these impulses are evoked by mechanical or thermal stimuli, which is called as the tactile allodynia. That is, just by touching the area, the skin feels burning or cutting pain. Nerve injury occur and result in persistent pain after acute phase in 11% of patients. Clinical features. The post-herpetic neuralgia commences in the 3 months after the acute infection. Patient report with variety of painful sensations, including spontaneous and continuous deep aching or throbbing pain, burning or lancinating pain, provoked by non-noxious stimuli such as contact with clothing or changes in temperature. The pain intensity is exacerbated by physical and emotional stress and alleviated by relaxation. Some patients with post-herpetic neuralgia have profound sensory loss in the area, that is anesthesia dolorosa. These patients may go to extraordinary length to protect the area from innocuous stimuli, while firm compression of the skin actually results in pain relief. The classification of severity varies from mild to very severe pain, and complications and comorbidities include depression, isolation, poor sleep, and significant impact on daily living. There is gradual improvement over time, but sensory changes take very long to recover. The management. First and foremost is actually reassurance and explanation to the patient that this is a neurological pain and you must have to overcome this neurological pain and come to your normal routine life as soon as possible to counter the long-lasting effects. Some guidelines suggest that topical lidocaine in form of a lidocaine patch or gel is used in accessible site, and the patch may be worn 12 to 18 hours and should be used daily for 3 to 4 weeks. First-line medications are either antidepressant like tricyclic antidepressant, nortriptyline, or calcium channel alpha-2 delta ligands like gabapentin or pregabalin. So these are the first-line treatments. Second-line treatment, depending upon whether antidepressant or antiepileptic was used, reverse the use. The non-pharmacological treatment include cognitive behavioral therapy or psychotherapy. Third-line treatment is opiate, analgesic, and tramadol. And in addition, we also commonly prescribe methicobol in such patients. Prevention. Systemic corticosteroids are not of proven efficacy in preventing post-herpetic neuralgia and hence not recommended as most of the people think that they are helpful. In older adults, oral acyclovir reduces the acute pain and healing time if treatment is started within 72 hours. So starting the treatment within 3 days of starting the treatment, 3 days of starting developing the signs of the disease is the best way to prevent this side effect. Famciclovir and valciclovir significantly reduce the duration, but not the incidence of post-herpetic neuralgia. A vaccine has been developed that decreases the incidence of both herpes zoster reactivation and post-herpetic neuralgia. Neuropathic pain. The neuropathic pain is defined by the International Association for the Study of Pain, IASP, as pain arising as a direct consequence of a lesion or disease affecting a somatosensory system. So the pain is as a result of direct injury. The updated international classification, painful cranial neuropathies include the trigeminal neuropathy, post-herpetic neuralgia, post-traumatic trigeminal neuropathy, and pain related to central causes such as multiple sclerosis, space-occupying lesion following a stroke. The trigeminal neuropathic pain syndrome. The pain in this condition is in the distribution of trigeminal nerve, and it is termed as the trigeminal neuropathic pain. Condition occur after 3 to 6% of the teeth that have been root-filled. Pain can also occur after removal of a teeth, especially the wisdom teeth, when the inferior alveolar nerve or lingual nerve are injured. It is also triggered by placement of implants or injection of local anesthesia. It may occur following healing of mucosal lesions such as lichen planus. The term painful post-traumatic trigeminal neuropathy is used for pain outside the oral cavity. It is considered more common in female and often comorbid with temporomandibular disorders and psychological factors. The clinical features. Most patients will link the start of their symptoms to some dental procedure. Patients often find it hard to describe their symptoms. The pain is continuous, at least 8 hour daily for over 15 days per month for 3 months duration. It is described as dull aching throbbing that is occasionally sharp or even burning. It is localized to anatomical area around the tooth and is often features of depression, anxiety, and somatization. There is marked allodynia in the area is typical, as well as hyperesthesia or hypoesthesia or anesthesia. Allodynia is altered sensation. The clinical variant, the location may vary, and it can be unilateral or bilateral. It is important to exclude the dental causes such as cracked tooth. Classification of severity. It varies in severity to moderate to severe, disease course, and prognosis. From the limited data, a third of patients improve and 10% become pain-free over 7 years period. Sometimes you need investigations like intraoral X-ray or CT scan to help find a cause, such as fractured tooth, inadequate root filling, or damaged local nerves. The treatment ladder. First line is reassurance and written information. Number 2, avoidance of further invasive treatments. Then maintenance of good oral hygiene and prevent further dental problems. Then simple analgesics such as paracetamol or NSAIDs. Second line include amitriptyline, SSRIs, gabapentin, or pregabalin. And even if the patient is not cured, then a multidisciplinary approach is used, including the cognitive behavioral therapy. The trigeminal trophic syndrome, which is, of course, different from trigeminal neuropathic syndrome. The trophic syndrome is an uncommon disorder in which chronic pain, burning, and stinging sensations in distribution of trigeminal nerves are associated with an irresistible desire to prick at the involved skin. So this syndrome is a two-phase disease in which there is a pain and then there is a response, an irresistible desire to prick the skin. The skin itself may be relatively anesthetic so that patient does not realize the damage that he or she is doing. Alternatively, the skin may be dysesthetic. The trigeminal trophic syndrome is rare but occur in all ethnicities and in middle-aged individuals and reported more common in men. Men to female ratio is 2:1. The pathophysiology. Neuropathic changes in trigeminal area may follow the destruction of fibers conveying pain and temperature sensations. Causes of this syndrome is central sensory neuronal damage, post-encephalitic Parkinsonism, syringobulbia, posterior fossa tumor, or occlusion of posterior inferior cerebellar artery, brainstem infarct, or damage to trigeminal nerve by attempts to relieve trigeminal neuralgia, for example, by surgery or alcohol injections. It may also occur secondary to herpes zoster or herpes simplex related neuritis. Trigeminal trophic syndrome is a disease of adults. The clinical features. Patient complain of paresthesias or sensation of itchy pain and burning in area innervated by trigeminal nerve. Then the area is picked, rubbed, and scratched, and the erosions increase in size and may extend to destroy the nasal cartilages. The picture shows the extreme degree of erosions in maxillary and mandibular distribution of trigeminal nerve. Patient freely admit that traumatizing the area to relieve the uncomfortable sensation, and pattern of ulceration is sufficiently bizarre to suggest dermatitis artifacta. Characteristically, the alar rim is involved and tip of nose is spared. Site less frequently involved are forehead, scalp, and cheeks. Neurological examination reveal decreased perception of light touch and pain over the area, and sometimes absent corneal reflex on the same side. Ulcers are complicated by secondary infection. The treatment ladder, emollients, and if necessary, topical antibiotics to cure the erosions. Oral treatment include gabapentin, pregabalin, amitriptyline, and SSRIs. Attempt to limit the self-inflicted skin trauma by wearing the gloves. Protection using appropriate dressing to promote ulcer healing. Second line, habit reversal cognitive behavioral therapy. Duloxetine and carbamazepine we tried with limited success. Third line includes surgical approaches including cervical sympathectomy, transcutaneous electric stimulation, and grafting or the use of innervated transposition flaps. The next topic is the dysesthetic genital syndromes known as the vulvodynia, scrotodynia, and penodynia. Vulvodynia is seen in women and penoscrotodynia is seen in men, and share many clinical characteristics and involve the genital skin generally or be site-specific. Some patients describe the provocation factors such as sexual and non-sexual touch. The disorders share common features in that they are idiopathic, chronic, and unresponsive to simple analgesias. Whilst the condition are associated with significant psychological comorbidities, Patients are not themselves psychiatric in origin. Condition occur in 8% of women and less common in men, 2%. Young adults are affected, but all the adult ages can be involved. All ethnicities are involved. Patients are generally anxious and depressed. There is sexual dysfunction, dyspareunia, erectile and ejaculatory disturbances. Patient may also have irritable bowel syndrome, fibromyalgia, and chronic fatigue syndrome. Clinical features. Patient often describes severe chronic, usually month or longer sensation of burning, stabbing pain, rawness, itching affecting either the whole genital skin or more specific part of the genital skin. Pain may be provoked by sexual contact or may be present all the time. There is usually very little to see by the way of physical signs. Patient may have localized or more generalized erythema affecting skin or mucosa. And the diagnosis is one of the exclusion. Complications and comorbidity. The psychosexual or psychosocial comorbidities are common. Disease course and prognosis. Untreated disease is usually recalcitrant. Treatment is usually successful, although it may take some time to achieve remission or symptoms amelioration. Treatment ladder. Start with topical lidocaine gel or ointment, then amitriptyline at a dose of 10 milligram and then build up. Oral tricyclics like doxepin. Second line include SSRI, gabapentin, pregabalin, and consider cognitive behavioral therapy if there is psychosexual or psychosocial comorbidities. Other anticonvulsants such as topiramate may be used. Then chronic scalp pain. Scalp pain and tenderness without any scalp disease is another mucocutaneous pain syndrome. Patient complain of severe chronic pain affecting the scalp or the hair and provoked by combing the hairs for which no underlying cause is found. Some authors indicate that thalamus may be acting dysfunctionally and lead to scalp allodynia. The differential diagnosis includes scalp dermatosis. In absence of scalp disease, the diagnosis of trichodynia can be made clinically with appropriate clinical history. Treatment ladder. First is education and reassurance, then use of gentle shampoos, avoid overzealous styling and dyeing. Tricyclics like amitriptyline may be used. Second line are SSRIs, pregabalin, gabapentin, cognitive behavioral therapy. Third line is acupuncture. Erythromelalgia. Erythromelalgia is defined by intense burning sensation of the extremities, usually feet, together with persistent fixed erythema. The incidence of erythromelalgia is 1.3 per 100,000 persons per year. An average age of presentation is 60 years, although diagnoses have been made in children. Erythromelalgia is more common in female. Pathophysiology. Many patients with erythromelalgia are found to have a distal cutaneous small fiber neuropathy that diminish pseudomotor function, that is sweating, and reduces sympathetic vasoconstrictive response, which results in increased acral blood flow. So usually the patient of erythromelalgia are associated with sympathetic dysfunction, dysfunction in sweating, and resulting in increased blood flow, peripheral blood flow. As a result, there may be reduced oxygenation to the skin and subcutaneous tissue, further provoking the symptoms. Secondary erythromelalgia is usually due to leukemia, thrombocytosis, and polycythemia, peripheral neuropathies, connective tissue disease, medications and poisoning, and pregnancy. So there is primary and then there is secondary erythromelalgia. Clinical features. The diagnosis of erythromelalgia is established clinically. Feet are most commonly affected, but cases are involving leg, hands, ear, neck, and face. Symptoms are intermittent, but usually there is persistent background dysesthesia with flares at night. Provoking and exacerbating factors include heat and exercise. Relief is achieved by cooling the extremities. Between the attack, extremities may feel normal or may be mildly cool, cyanotic, and uncomfortable. Patient often lie in bed with feet facing an open window or lying on cooling ice packs. Both of these conditions or maneuvers are counterproductive and exacerbate the disease. The differential diagnoses include peripheral neuropathy, connective tissue disease, Raynaud's phenomena, acrocyanosis, and peripheral vascular disease. So this is how erythromelalgia will look like. Extreme degree of erythema on the feet and maybe in the hands. Management. Treatment of erythromelalgia is difficult and usually achieved through trial of medications. For mild disease, topical treatment is first line, that is lidocaine patch, doxepin cream, or capsaicin. For moderate disease, the topical should combine with oral and systemic therapy like gabapentin, pregabalin, SSRIs, amitriptyline, or nortriptyline. Third line include intravenous agents such as lidocaine, sodium nitroprusside, or prostaglandin. Cognitive behavioral therapy and talk therapies may help in some. For patients not responsive to medical treatment, invasive procedures like sympathetic blockade, sympathectomy, and dorsal cord stimuli may be considered. Patients should be educated to avoid the provoking factors such as warmth, dependent positioning, exercise, alcohol. Behavior that exacerbate the condition like ice packs should be strongly discouraged. Prognosis variable. Some patient responds quite well, whilst few seems to have recalcitrant and difficult to treat disease. So this brings to end of the short lecture. I hope that these syndromes have become more clear to you, and you must appreciate that all of these syndromes, they have almost similar treatment, which include the several SSRIs and triptylines and the gabapentin or pregabalin, along with talk therapies, cognitive behavioral therapies, and rarely surgical interventions. So thank you all for patient listening, and see you next time with another edition of my lecture. Have a very good day.